First of all, we want to welcome everybody that's joining us today. It's our honor to do this webinar and hopefully to give some information to everyone. My name is Lara Marcuse, and I'm co-director of the Mount Sinai Epilepsy Division.
And I'm Fedor Panov. I'm one of the neurosurgeons at Mount Sinai, and I'm the director of the adult epilepsy surgery here.
And we're obviously based at Mount Sinai. We do all of this work at Mount Sinai. We're very attached to Mount Sinai, but we hope that people from around the country are going to be able to watch this. And if you're really interested in epilepsy care, there's a lot of level 4 epilepsy centers around this country, and those are the places to go. Okay. So what we're going to do today is we're just going to talk a little bit about epilepsy and drug-resistant epilepsy and different treatment options. And we are so lucky and honored to have Megan with us, who's a person with epilepsy, who's undergone a lot of different treatment options, and we're going to go into that. And then we really want to hear your questions.
So to start here, I think it's really important for everyone on the phone call to realize you guys are not alone. There's a lot of people out there who have epilepsy. So if we go by worldwide, it's about 70 million, which means about 3.5 million in the United States are living daily with this disorder. It is the 4th most common neurological disorder nationwide. And every year we have about 150,000 new cases that come up.
So, what is a seizure? Let's just go back to basics. Seizures can look like so many things. The technical, wordy, neurological definition is a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Oh.
We'll just make sure that we're
sharing.
Yep, just give us a thumbs up if you guys now see the slides, epilepsy overview.
Yep, we're seeing epilepsy overview and what is seizure, the first one.
Okay. Were you seeing it before, or did you just start to see the slides?
No, we've had them.
Okay. So seizures can be things that we typically think of as seizures, like falling down and shaking all over and frothing at the mouth. Seizures can be a very intense feeling of fear. They can be picking movements. They can really look like different things depending on where in the brain they are. And epilepsy means that you're having more than one seizure and that it's not provoked. So if you have a lot of seizures because you're giving yourself too much, insulin because you have diabetes and your sugar is tanking, that's not epilepsy. That's just seizures as a symptom of your medical illness. But if you're having unprovoked seizures, then that means that you do in fact have epilepsy. And it's an important word to use. People don't necessarily want to hear it, but it's important to use the accurate words and to work on some of the feelings that might arise, that might feel like stigmatizing, and to really work on that as kind of a separate issue. There's so many different causes of seizures in epilepsy, and many, many times I can't give my patient the answer as to why they have their seizures. Sometimes it's caused by a difference in development of the brain. Sometimes it's caused by a difference in genetics. A history of traumatic brain injury can cause it, brain tumors, strokes can cause it, and metabolic changes. So there's many, many, many things that can cause seizures in epilepsy. When you come to talk about it with an epileptologist, one of the most important things that happens is you telling the doctor what you feel. So when you tell an epilepsy doctor that you get a feeling of memory, you are really telling the doctor where in the brain your seizures are coming from. The other thing that's really important is what happens to you during a portion of the seizure that you might not be aware of. And for that, we may need to call somebody, a witness that's seen your seizures. We also do tests like EEG and brain imaging, and we take a medical history. And these are all really important components of making the epilepsy diagnosis and also any initial visit. When we're thinking about seizures and picking medicines, we need to know if the seizure started everywhere in the brain at once, and that's generalized down here, or if it started in a little piece of the brain, and that's focal. Another really important thing to talk about at visits with your neurologist is more about you. Like, who do you live with? How do you spend your time? Do you go to school? What are your goals? What makes you happy? What makes you unhappy? Because the goal is to have a wonderful life, a wonderful and deep life. And that's what we're trying to kind of move towards. And the way to get there is to really minimize the side effects of the seizures and also any treatments for the seizures. We also really like to talk to people about their mental health and investigate if more support is needed. Here's, some information about anti-seizure medicine. It controls seizures for about 7 out of 10 people living with epilepsy. So that's pretty good. And different medicines can help with different seizure types. Newer medicines tend to have fewer side effects, and there are a lot of medicines to choose from. And there's often another benefit, like maybe somebody has headaches, so we can pick a medicine that will also help prevent their migraines. There's also limitations and risks. So many people who are watching this probably know this better than I do, that there can be a lot of side effects of medication, and we have to take that very seriously. Sometimes the person who's taking the medicine won't necessarily know that the medicine that they're taking is causing the side effects. So they might feel like their partner is being incredibly rude and really terrible and very inconsiderate, and they're furious with their partner all the time, and they don't understand that it's actually a side effect of the medication that's causing the increased irritability. So that's another important reason to have really good communication with your doctor, because we can help investigate what is a side effect of the medicine and what's not. The probability of seizure freedom with medicine declines if there's been like 3 medicines that have been tried and they haven't been successful. It's less likely that the 4th is going to be successful. At the same time, don't lose hope, because there's some newer medicines that are on the market that might be a little bit more effective. And I definitely have worked with people where we've worked together for many years with different medication cocktails, and we do come to something that works. So it is important to be optimistic. Medication compliance is really, really hard. And everybody who is listening right now should know that. And it's really worth talking to the people around you to develop a game plan to take your medication perfectly. Because if you suffer from epilepsy, you have to take your medicine perfectly. It's not like anti-cholesterol medicine, where if you miss a few days, it doesn't matter at all. You have to take it really well, or you could have an unexpected seizure and you could have an injury to yourself. And it's and a really bad consequence of it. So I really encourage people to spend the time to think it through. Are you going to use a medication box, or are you going to use a timer? What works for you, what doesn't, and really try to kind of quantify it and be very mindful and get support for that. Also, different people have different triggers. So for some people, if they drink, 3 alcoholic drinks, they're guaranteed a seizure the next day. For some people, if they get poor sleep, they're guaranteed a seizure the next day. For some people, if they're watching flashing lights, they'll have a seizure right there and then. So it's really important to identify your triggers and to avoid them. Having a chronic medical condition is really hard. And it is really important to continue to grow as a human being and to develop your hobbies, to deepen your relationships, to develop your career. If somebody has an intellectual disability and doesn't have like a career, it's still important to develop new things that are going on in program. It's really important to have kind of a holistic approach. Taking care of your mental health, I kind of alluded to that a little bit. But anxiety and depression and epilepsy are like best friends. They're skipping together, hugging each other. Nobody wants to let go of anybody in this kind of like evil triad of anxiety, depression, and epilepsy. So we will really want to look at what might help if you are suffering from something, from some negative feelings. Counseling, community therapy, group therapy, and medication are all tools in the toolbox. For some people, it's something totally different, like Tai Chi or yoga. But the most important thing to know is you really deserve support. You deserve kind of exquisite care. Exercise and good nutrition, like these basic things, those are also really important aspects of mental and physical health. There's a lot of other things that might be surrounding epilepsy that feel really personal, like some people have sexual side effects due to the medication, and these are also things that are really okay to bring up with your doctor. my colleagues did the most fabulous webinar last year on women with epilepsy. So I really encourage you to, you know, we can try to surface that webinar for you. But hormones really can affect epilepsy. If you're a woman with epilepsy and you want to have a baby, you absolutely can have a baby. There's definite ways to make that as safe as possible. And again, it's about communication. And we also, it's really good to plan in advance so we can make sure that you're on the correct supplements and the best medication that's safest in pregnancy. But we also really understand that pregnancy is often unplanned. And if you have an unplanned pregnancy and you want to keep the baby, an epileptologist can really support you through that process. Also know that women with epilepsy are encouraged to breastfeed. And these things are really important to talk about. If you go on a new oral contraception, it can interfere with some of the anti-seizure medicine. So again, it's a really important thing to bring up.
So the next thing we want to cover is what it is that's possible to do if the seizures don't stop. So as you guys can see from this illustration, about a third of the patients will not achieve seizure freedom with medication. And even one seizure a year can be too much for a person to be able to maintain what it is that they want to. So what can cause this kind of drug-resistant epilepsy, right? So epilepsy that breaks through the medications that you're using. So one of the common types is unknown. We really are never going to be able to fully home in on what is causing your seizures. You can have worsening epilepsy patterns. You can have alterations in the networks of the brain that cause this. This could be you slowly developing a tolerance to one of the medications. It can be something that is affecting your brain. So you can have a small brain tumor growing somewhere that is starting to press on areas and cause seizures that way. Or it could come from genetic factors. The other possibilities and things to keep an eye on is epilepsy severity, right? So it can get worse. And of course, the comorbidities that Dr. Marcuse mentioned, depression, anxiety, those can also get worse and they make each other worse, which is unfortunate. Epilepsy can come from inflammation in the brain, as well as other possible disease etiologies. And there could also be a structural abnormalities. So on its own, you can have a small, stable lesion inside of the brain that's not causing you any harm, but unfortunately where it is, causes these electrical storms to happen. So we need to work that up as well. And drug targets are definitely very important for us to consider. And depending on where specifically the seizures live inside your brain, different drugs can work.
And the only thing I'll add to that is seizures beget seizures. So if somebody has a long period of time in their lives where the seizures weren't recognized, that is always, and they weren't on anti-seizure medicine, that epilepsy is going to become that more difficult to control.
So the important next step is just to realize what it is that people are up against if the medications are not working. So these are some of the consequences of uncontrolled seizures, and they're serious. Increased risk of emotional behavioral problems. If the seizure is not controlled, again, the depression can get worse, the anxiety can get worse. You can hurt yourself, and unfortunately, you can hurt others. So it's very important to keep an eye on that. Intellectual and learning problems can arise, right? So these storms will prevent potentially your memory from working as well as it can be. So if you're running into continuous problems in school or in college or at your job, it's important to address. And this is a difficult one to discuss, but there is a small chance of death during a year in anyone who has uncontrolled seizures, and that's called sudden unexpected death in epilepsy, SUDEP. And it's a nightmare for all of us here as a team that are treating patients. That's horrible for patients and families, but we need to face this head on because unfortunately that's a possibility for a lot of folks around the country. Difficulties at work, as we mentioned before, right? So you may have trouble at work, but you may also have trouble with the control and dexterity of your arm or your leg. And that also something that needs to be looked at because those things can get worse. And of course, the side effects of the medications, right? They're not to be looked down upon. Like the medication itself can actually make your life much more difficult. They can make you sleepier, they can make you more tired, they can make you feel like you're just in a fog. So you need to make sure that you explore your treatment options. And as Dr. Marcuse said before, a level 4 epilepsy center, the closest to you one, is the right place to do this. So should intervention be considered when you're talking about the advanced treatments? So if you've tried 2 medications and you continue to have seizures, it's probably important for you to get to a level 4 epilepsy center. If your seizures are socially disabling, if they affect your day-to-day life, or if they affect your quality of life, and remembering that you are at an increased risk of injury. right? If your seizure duration is excessively long, so to make sure that you avoid some of these possible downsides and complications, including neurological decline and SUDEP, it's important to be seen at a comprehensive epilepsy center. So considerations for advanced interventions include an admission to a center that can perform a video EEG, close attention to the seizure symptoms, and imaging, including an MRI scan of your brain, as well as a test called neuropsychological testing, which can give your physicians a lot more information about what types of seizures you have and what parts of the brain they are affecting. Other tests may be ordered as needed as you go through this process. And we're slowly, as a team, together with you, creating a hypothesis of where is the seizure onset zone? What part of your brain is mostly responsible for creating these electrical storms? And something like a stereo EEG may be needed. So Megan went through one of these with us. Now that, for all intents and purposes, is an EEG, electroencephalography, that is done from the inside of the brain itself. So as you guys can see, sometimes a friendly robot will be helping, as you guys can see on the left here. And it's a minimally invasive procedure that is done with the patient asleep in the operating room. And we have a couple of leads here to show you. So it's a tiny little thin wire, if you can see here, that is threaded into the specific area of the brain that are part of the hypothesis. And once you wake up, you have stickers on the outside like you do for an EEG, and you also have these tiny contacts on the inside, and all of the areas that need to be potentially ruled out. And then you stay in the hospital with us for 1 or 2 weeks until we capture the seizures, and we can give you much more information about your possible treatment at that point. And we're going to go through a couple of therapeutic interventions that are available nowadays. So, for example, if we find a spot somewhere inside of the brain that you do not need, it doesn't do you any good, but it is deep and it's hard to get to with something like an open surgery, minimally invasive laser ablation has been around for more than 10 years now. Now, this is a robotically guided procedure that will deliver a really small laser about the same size as the catheter you guys just saw here. And that laser ablation will deactivate a small area of the brain, and that has a good chance of offering seizure freedom to a lot of patients. It's done through a very small opening in the skull, about the width of a pencil. The procedure is performed with the patient completely asleep, and it's guided by the MRI scan, and it precisely delivers that energy just to that one spot. It's continuously monitored, so the moment the heat is starting to spread to an area that we don't want to affect, we can go ahead and stop the treatment. And the incision is really closed just with one staple or a couple sutures, and the hospital stays about 1 to 2 days. So now we can go through a little bit more in details as to the potential candidates for this kind of minimally invasive laser ablation. You do need to have a clearly defined area that causes the seizures, and you should have seizures that are not well controlled by medications. Also, in the majority of patients where we introduce this to, they probably would benefit specifically from this minimally invasive approach to epilepsy surgery. The benefits are over 50% of the patients in a well worked up case will have seizure freedom at 1 year. And study shows that patients will improve their quality of life and social function. You do not have to shave your head, and the scarring is minimal. The ICU stay is also minimal, usually 1 night, and the post-procedural pain is significantly reduced because of the minimally invasive nature of the procedure. Now, some of the risks and the limitations is you need to be able to get an MRI because that's what guides the procedure currently. And there's possible complications of swelling or a little bit of bleeding around the area of the catheter. Some headaches are potentially expected after the procedure, and those get better. And it's very infrequent that you will have other neurological issues like visual impairment or memory impairment. So now we'll move on to another potential treatment. Let's say the area of the brain that causes the epilepsy for you is something that you need to keep. Let's say it's something that allows you to remember a loved one or to move your left hand. Then most certainly deactivating that area is not a good idea. No surgeon or epilepsy team should ever propose that to you. But about, at this point, 11 years ago, a company called NeuroPace created responsive neuromodulation. And that is where you have a small device implanted inside of your head, and it's kind of like a pacemaker. It is continuously detecting the activity of the brain in the area where the seizure can start. And the moment that it's starting, it sends a little countercurrent from the smart battery to attempt to stop it. Now, the way that we usually describe it, it's as if you're pouring some water onto a matchstick in the middle of the forest before it becomes a forest fire. So for this case, what we do need to do is we need to place a little smart device that's going to live inside of the skull itself. Dr. Marcuse is showing it currently. It's only about 2.5 centimeters by 5.5 centimeters. but it does require a slightly larger opening through the skin that is always behind the hairline, so it's well hidden. And then the device gets implanted and secured to the skull itself, so it does not move.
And it's flush. It's not like sticking out of people's head. It's flush and there's, hair
Hair
on
goes
top.
over
And
the
it's
top.
actually sometimes very hard for me to find it when I'm like using the wand. That's how flush it is.
And then the small thin wires called leads, again, are connected to that device, but they come from the epilepsy foci themselves. They come from the area of the brain that need to be chronically monitored for this. The hospital stay for this procedure is also 1 to 2 days. And again, the scarring can happen, but it's all behind the hairline and the hair grows back because we shave very minimal amount for these cases. And then the patient at home will get a remote monitoring system and they're able to communicate with the physician and download their seizure data and stay in touch with the team as the device is being programmed to get better and better and better. So who can be considered for responsive neuromodulation? Well, again, these are patients who do not have their seizures well controlled with current treatments, and they're not able to have a resective or an ablative method that could help them. The benefits are significant. So at 1 year, about 2/3 of the patients will experience significant seizure reduction. And the trials for this have gone all the way out to almost a decade, where 3/4 of the patients experience significant seizure reduction. So on average, the complications from this regarding the stimulation and the treatment of the seizure are minimal. There is no effect of mood or cognition or other stimulation-related side effects. The device is something that can always be removed or turned off if it's something that a patient does not like. And it does decrease the risk of SUDEP, which is a big deal. So the risk of dying from epilepsy per year goes down with this device.
I would add that one of the most amazing benefits of this device is it gives me as the epileptologist a lot of real-time data on people's seizures. So they upload data about their seizures to the cloud and some people aren't sure if they're having a lot of seizures, or they wake up groggy, and I can tell them that they had a seizure last night or they didn't have a seizure last night. And it really, I think that part of it really improves care.
The risks and limitation of specifically responsive neuromodulation is that it is usually not seen as something that will give a patient seizure freedom. Now, that's with a big caveat that in our system, we have about 10 to 50% of the patients whose seizures are so drastically reduced, they no longer feel them, but that's not the majority of these patients. And there's a small risk of infection and bleeding and pain at the site as you're going through the procedure itself. It is almost always still used with some seizure medication. And the typical battery life currently is about 8 years. So in about 8 years, if you're using this device, you will need a small procedure to change the battery. This is a wonderful graph that shows what happened when they did the trial to see how well this would work in human beings. So you see at year 1, 44% of patients had a 50 or more reduction in their seizures, but by year 9, it was 75. Now, when this went live and a lot of centers were able to implant it, and as we learned how to program the device, we can see that it got a lot better. So currently, we're seeing efficacy at year 3 that is actually greater than efficacy was at year 9 before. So the team is getting better at using it.
Sorry.
That's okay. Deep brain stimulation is another possibility, and that's similar to responsive neuromodulation. That is a device that is implanted in a similar way, but the battery itself goes under the collarbone here, and the extensions connected to the brain leads. So little smaller incisions on the head itself, but an additional incision onto the collarbone. And currently, this device continuously stimulates in the hopes of preventing a new seizure from happening and decreasing the severity of a seizure that is currently ongoing. The potential candidates are very similar to responsive neuromodulation. Your seizures are not well controlled, and they cannot be helped with other types of surgeries that can aim at a potential cure. The benefits are significant. So at 1 year, about 4 out of 10 people will experience less seizures, and at 5 years, almost 2/3 of the patients will experience less seizures. It can positively impact your quality of life. The device, again, can be turned on or off based on your wishes. And most likely, some of the anti-seizure medications will be able to be reduced over time. We can also change the stimulation settings if there are complications from STIM. Now, the risk and limitations here, again, it does not usually eliminate seizures entirely, and it should still be used with seizure medication. There's a small risk of infection and bleeding in the brain and device malfunction long-term. We always have to keep an eye on these devices. Currently, the replacements are about every 4 to 6 years. The last one to discuss here is vagal nerve stimulation. That is a smaller surgery that is done in the level of the anterior neck. And here we harness the power of one of the big nerves in our body called the vagus nerve. And the surgical team will carefully open this area and wrap tiny little coils around the vagal nerve that lives here. And the signals that it will send up to the brain will increase the defense of your brain against seizures. The wires that are coiled, as we just discussed, typically it's an outpatient procedure. You may stay for one night, and the scar in the neck usually heals very well. It may take a few months before this device is really up to speed and helping you as much as possible. And the way that we usually talk about vagal nerve stimulation is about a third of the patients will experience significant benefit, about a third of the patients will experience some benefit. Unfortunately, it may not work for about a third of the patients who try it. So it should be considered for patients, again, who have seizures that are not helped by other ways, who are over 4 years old, and they cannot have some of these other surgeries. The benefits are that mean seizure reduction can be approximately 50% in 1 year and may continuously improve. Recovery after the seizure is a little bit shorter for some people versus other neuromodulations that we discussed. The device, again, can be deactivated and removed if needs be, and it's a quick procedure. The downside, again, it does not completely eliminate seizures. It may take a few months or up to a year or 2 years before it's fully working for you. You need to use it with meds. Side effects from this include a little bit of irritation around the throat and potential cough when it's treating you. And if the leads break down, just like all of the other hardware we discussed, it may need to be replaced. Battery expectancy is somewhere about 6 to 11 years currently. Now, open resection is one of those things that has been around for the longest time, and that is a small, carefully tailored procedure. If we do find in an area of the brain that you do not need but causes the seizures themselves is easily accessible, we can go ahead and use minimal hair shave. And you can see here a CAT scan showing how small a craniotomy can be, a small opening in the bone in the head that allows us to get to the area. The brain tissue that is causing the seizures is carefully resected, and then the bone flap is placed back over and the skin is closed. The hospital stay for this is usually 2 to 3 days, and there could be some post-operative swelling and pain that resolves within 1 to 2 weeks.
And we're going to show a picture of an actual brain right now. That's an example.
So yeah, so this is the opening in the skin itself with the patient under general anesthesia that shows the opening and the bone surface. And here you can see the completion of the surgery was a small area of what's called the parietal lobe has been resected carefully, leaving all of the brain that the patient still needed around to cause them to be seizure-free.
And this procedure was curative. Yeah.
So the benefits of open resection is you have, a clearly defined area, and it's easily accessible in surgery. You are a candidate for this, and your seizures have not been controlled by other methods. About 70% of these patients, if appropriately worked up, can be seizure-free in 1 year. And the studies show that these patients will experience improved quality of life, even if some seizures still do remain. It's probably the most long-lasting and established procedure that we have in our epilepsy center. The downsides are potential visible incision and scar, and complications from the surgery itself that could, in some cases, include infection, additional hospital stay, neurological issues that usually are temporary, visual impairment, problems with memory. So make sure that you do discuss this carefully with your team. This is the kind of surgery that's one done is not reversible, like some of the other methods that we discussed. So an appropriate good plan at a comprehensive epilepsy center is incredibly important for these cases. But the risks are lower than you think, and the risks are not what they used to be even 10 years ago. Some risks are common to all types of surgery. Some are specific to operating on the brain. Bleeding and infection can happen in any procedure, but it's specifically worrisome for us in brain surgery. So we are utmost attentive to what we call hemostasis, controlling bleeding during the case itself. And of course, all of the instruments we use are checked by the infection department, and they're sterilized before we give you antibiotics for the case. The risks may vary depending on what type of brain procedure you have. So please discuss this with your treatment team. And of course, the greatest benefit of any epilepsy surgery is having no seizures or having much fewer seizures. So when you're considering all of these things with your team, weigh the risks and the benefits against the significant risk of having continuous uncontrolled seizures.
So right now we want to introduce you to Megan, who's here on the call. We're going to go through her story, and then I'm going to ask her a couple of questions so she can talk directly to you. But one of the reasons why we wanted to pick this story to highlight is because there was a lot of different things tried here. And I want everyone who's listening to kind of be optimistic and to continue to try and always, even if seizures are ongoing, always work at the other parts of life to make them better. Megan lives with her husband and she loves dogs. So she probably has a story about that handsome dog right there. She has a master's in forensic psychology and she works in clinical research. And I tell those things about her very for a good reason, and that's because the whole person really matters. The whole person really matters. She began to have seizures when she was 11 years old, and her epilepsy was drug resistant, and she has a structural brain abnormality, and the name for that is periventricular nodule heterotopia. That structural abnormality is on both sides of the brain, but we had a strong suspicion that the seizures were only coming from one side. The seizure that was really bothering her when her and I met was this feeling that she was taking a half step out of her body. She would feel disconnected, fearful with a tingling sensation in her chest, and she would have difficulty speaking. And those were happening several times per month. We actually met because she came to one of our clinical trials. We're doing a clinical trial to see whether ketamine in the doses that are used for depression can help with seizure control. And it was 6 infusions over 2 weeks. This is a clinical trial. It's not actually approved yet. And this showed an improvement in her anxiety, which kind of really lasted for a long time, and a slight reduction in seizures. And also we got to know each other through this trial that she underwent. And we kind of all met and talked about her, and we looked at all of her previous data and her imaging, and we really thought that the epilepsy was secondary to the periventricular nodule heterotopia on the left side and close to the temporal area, because some of her symptoms were temporal, but we won't get too much into that. And then she underwent that bilaterally stereo EEG because the abnormality was on both sides, even though we kind of thought it was going to be coming from the left. And that was in March of 2023. And then we captured her very typical seizure. This is her very typical seizure. I don't think I'm going to play the video because we couldn't really hear it so well when we did a little dress rehearsal. But during this video, the staff comes in, she gets up and she presses the button. Maybe I can play it a little bit, even if you can't hear it. And then the staff walks in to evaluate her, and at first she's following every single command perfectly well. They're saying point to the window, she's pointing to the window, point to the door, she's pointing to the door. She's perfectly crisp. And then she stops being able to speak and she stops being able to follow commands. And that all happens pretty quickly. So right now, this is, she's totally aware. She's speaking completely clearly. And this is really important information for us to know, that she can speak during the beginning of her seizure. In terms of a surgical workup, it's really important because you only need to take out the onset zone. So she's answering everything. She's doing amazing. And then she has a little bit of automatic movements and she stops being able to respond as well. And this is the picture of the brain waves that we're looking at. And like, I know that everyone on this call wants to learn how to read these squiggly lines and finds it as interesting as I do. But, you know, call me later and we'll go through it. But it turned out that the onset was coming from a part of her brain called the hippocampus. And we did a very nuanced test of this hippocampus, and she needs this hippocampus for her memory. Her memory score in that hippocampus was excellent. So we could make her seizure free by taking out that hippocampus, but we would also cause damage and her difficulty with her memory. So we did not offer that procedure. We did find out another little thing. This is her and I talking to each other at the bedside, and she was talking like completely normally, like so eloquent, so articulate. And then she just lost her train of thought for like 3 seconds. And what we found from that, and then I turn around and I look at the brain waves. And what we found from that is that when she was losing her train of thought, it was actually a tiny seizure coming from an area of the brain that we could actually deactivate, that was safe to deactivate. So her main seizure that we knew about, we knew it was a seizure. We could not take that out because that would hurt her. But this other little seizure that she'd been experiencing all the time, but we didn't know was a seizure, that we could deactivate. So we, and by we, I mean Fedor Panov, did a laser ablation. Do you want to take them through this?
Yeah, for sure. And as you guys can see on the upper left-hand corner, that's an MRI of the brain, what we call an axial cut. And what Dr. Marcuse is pointing to right now is that little bit of artifact, that black line that's going posteriorly. That is the laser probe itself. And then in the middle, in the middle of the screen lower, that's a post-ablation scan. And Megan, this could be one of the first times you're looking at, the amazing thing that happened for you here is that heterotopia is now deactivated all along that laser track going from anteriorly to posteriorly. So there was a significant improvement in the frequency of these tiny seizures. And then 2023, you guys adjusted some of the medications. And again, the seizures seem to have been shorter and you would spring back quicker from this specific minimally invasive laser ablation treatment.
And there was a new medicine that came out called cenobamate and Xcopri, which really has like really good stats. So again, like I have a very like by any means necessary, let's try everything, let's keep an open mind. And so we tried this new medicine and we really gave this like a good long time, but she was still, even though the seizures were shorter, they were still happening. Oh, by the way, this is her a few days after laser ablation. So if you think you're going to be like, this is you a few days after laser ablation, Megan?
Yes, I think it was either like not even a few, 1 or 2
Okay, that's amazing.
after I got out of the hospital.
Yeah, that's it. That's
It
amazing.
was nothing, like in and out. I think I was watched overnight and then I went home like nothing happened.
But I just want to be clear, she does also have her normal real hair is under that thing.
Yes. She didn't shave off all her hair. That's not why she had to do this. So in December of 2023, we did, and again, by I mean Dr. Panov placed the RNS device. Now, we said that we could not remove that hippocampus, but we could put an electrode in it to start to treat those seizures. So one electrode is in the hippocampus and one electrode is in a part of the brain called the thalamus, which is a very central location that's very good at kind of reaching a lot of different places in the brain and kind of desynchronizing the epilepsy network. And this is what I'm talking about when I say I get really good data from that RNS. So this is inside of her head. This EEG is kind of going on at all times. And when it would detect a seizure, it sends me this incredible picture. So I would be able to see it. So this is a seizure from her left hippocampus, and I could see it so well. So this is a picture from January of 2024 to March 2025. This is all of the activity of the RNS device, but this is all of the activity. So it actually doesn't actually give me that much information, and it's a little bit technical as to why. But this was a moment in time right over here where everything looks like it's going down, where I actually changed detection, and that's why it went down like that. So that's not the real information. The real information is in this next picture. This is the picture of her long episodes. Her long episodes are in fact her seizures. And over time, she stopped really having seizures. So she's one of the people that is seizure free with the RNS device. And it's been, I think, about a year, Megan, since your last seizure.
It'll be a year on March 30th.
Okay. And
Almost.
here, I guess we can guess this is another day in March where she's, is that your husband?
It is, yes.
Yeah, hanging out with her husband. And so she's been seizure free for about a year. And before we get to questions, I just wanted to ask, I'm going to stop the share so we can see Megan. I wanted to ask Megan some questions. So can you talk a little bit about what it was like for you to have seizures as a child and then growing up and to kind of live with them for how many years did you have active seizures for?
I can remember them as far back as early middle school. If they happened earlier than that, I don't remember. So it was a good 10 years probably before I even knew what was going on. I had the feeling of fear coming up behind me. Weird, like tingly feeling for about 2 minutes, maybe, because I didn't really have a good sense of time. And then they went away, and I tried telling my parents once and a doctor, and they were like, oh, it's probably just nerves, nothing to be worried about. And it was, I think like 3 days after my dog tragically, like suddenly passed away. I was home and I saw this happen to her. And I think they think the stress of that is what caused me to have my only grand mal seizure that was outside of a clinic setting. And after that, they're like, oh, you have epilepsy. And the first doctor I saw was kind of like, yeah, here, take these meds. You have epilepsy. See you later.
That doesn't sound very supportive.
No, and I went and I found another doctor, but that was still 20 plus years ago.
So when I met you in 2022, we met for this clinical trial, and
Mhm.
at that time, like, you didn't seem that interested in like surgical options, and then you actually ended up basically having the courage to go through so many different processes.
Mhm.
What gave you that courage?
Um, so I think the primary thing was I had, prior to when we met, I had been told by both NIH and Johns Hopkins that I was not a surgical candidate. And at that time, back in, I think it was 2018, they didn't want to do the stereo EEG on me. So same picture from the MRI, there's too many spots. We don't want to go messing around in there because we don't know exactly where it's coming from. So because I work in research, I occasionally, every so often, when I was looking for trials for work, I would also, search epilepsy, see what was coming down the pipeline as far as new medications. A lot of those trials, though, you had to stop what you were on and possibly placebo, and I didn't want to deal with any of those. And then I found your study. And from there, you introduced me to Dr. Panov, and I think just the team being so supportive was able, working together, like you said, put together a treatment plan for me. And it was kind of both of you, along with my husband and my family, that convinced me to keep trying and keep going and try these new surgery options. I had heard about the laser ablation, but again, 5 years prior, I was told it wasn't an option for me. And then it was.
Yeah, and I want to say that when we did your laser ablation, we knew it wasn't going to be curative. We knew it could only treat the smaller little space outs. So you also came with this like pretty intense anxiety. Can we talk a little bit about where your anxiety is at now?
Yes, I think, retrospectively, I think my anxiety was majority caused by when I was going to have another seizure, and also the lifestyle that had been created from all these medications that I was on. Like you said, trying every new medication brought a new side effect. And at one point, I was taking medications 3 times a day, and I had it so in my head, if I don't take these medications, I'm going to have a seizure. If I don't get enough sleep, I'm going to have a seizure. The seizures and the anxiety just compounded each other over and over and over, to the point where I was on so much anxiety medication. And it took a very long time, but I was able to get off of it. And the ketamine trial definitely helped just bring it down. And then feeling better first after the laser ablation, because the seizures were shorter, and I didn't feel that overwhelming need to take a nap after every time it happened or go to sleep. I was able to start getting a better quality of life and take less anxiety medication, to the point where I don't need any anxiety medication anymore. And that's been a huge triumph.
That's kind of amazing. And then, you have an audience here of a lot of people listening on this webinar, and, some people are really still struggling with seizures. And do you have anything that you would like to impart as someone that's sort of been through so much with this?
I would definitely say don't give up. 20 years ago, I was told all you can do is pop these pills. And, I tried 3 and, oh, they don't work for you, but you can't have surgery. I think the biggest thing is to surround yourself with family, friends, activities. I used to run, but an elevated heart rate was definitely one of my triggers. So I switched from running to yoga, and it's calmer and it was relaxing and helped anxiety. And I think a big part was being able to work, and my coworkers knew what was going on, so they could jump in if I was on a meeting like this and suddenly I kind of just trailed off. Somebody knew to like jump in and kind of pick up, so people watching wouldn't necessarily know what was going on if they didn't know my medical history. So that was a huge benefit. I've encountered, I guess I wouldn't call them friends, but people who, when you call at 8 o'clock at night and say, you know what, I really don't want to feel like coming out. I didn't get a lot of sleep. I'm worried about, maybe having a seizure if I have one too many drinks or stay out too late. And they're just like, oh, come on, it's not that big of a deal. Well, it is a big deal. So eliminate those people from your life and surround yourself by people and physicians and just everyone who can support you and work towards that goal. Something hopefully will come along.
Megan, thanks so much for joining us. I know like to hear a real story is like the more interesting part of these talks. Like Ted and I just talking is, I think, probably a little boring for everyone. So we really appreciate
And
you.
I've had what you've gone into this side of my head 3 times, and I mean you can't tell.
Yeah, look at so that and Megan does have the RNS device like right here. We have a whole lot of questions, so we're not going to be able to get to all of your questions. I want to address one of them from Kira, who says that she's been on Keppra and she has 4 children that she breastfed. There is really good evidence from JAMA Neurology that looked at women who breastfed and women who didn't, who have epilepsy, who are on levetiracetam was one of the drugs, and the women who breastfed the babies did better. Keppra does get into the breast milk and the babies do better. So women with epilepsy who are on Keppra are encouraged to breastfeed. So you did amazing, and that's of great benefit to your children. Let's think, which other question do you want to take?
Yeah, there's a question from Nick Lee about the keto diet. So absolutely, that is one of the choices. From what I understand, and again, I'll defer to Dr. Marcuse, but it's exceedingly difficult to maintain because that's not the keto diet that you think about for losing weight. It's a much stricter version. But if that's something that works, because our brain does run on glucose, so you sort of take away a little bit of whatever's in the armamentarium for the seizure to start. So keto diet can work and it's worth trying, but make sure it's an advice by your treatment team. We also had a question about methylene blue, which unfortunately I know almost nothing about, and nicotine patch. Again, sorry, but we will look that up and let you guys know. Gail says she had AVM gamma knife surgery, which is one of the treatments for arteriovenous malformations, and had a few seizures. If you're still having seizures, even 1 seizure a year is too much, Gail. So we suggest you see a good epileptologist, a neurologist that specializes in this, and let's try to get it under better control.
Okay, so somebody's asking if you have primary generalized epilepsy, how common is it to get better and disappear with age? It really depends on what type you have. So there's a whole bunch of different types of epilepsy that fall under that category. If you have juvenile myoclonic epilepsy, which is a primary generalized epilepsy, you're going to need medication for life, and you're going to do amazing. It's good and it's bad. But people who have juvenile myoclonic epilepsy do better with medication for life. If you have something like absence epilepsy that started when you were 5 or something, you have a really good chance of outgrowing that. So it really depends on the specifics. And the ketogenic diet came up in this question too. I would only recommend the ketogenic diet if someone's epilepsy was really, really hard to control with medication. The ketogenic diet is one of the hardest things to actually do properly. And I also want to say that for the devices like the responsive neurostimulator or the DBS, they tend to have far fewer side effects than a lot of the medications that we use. And I think people don't really realize that. People get really like, they think it's going to be like full of side effects. Like maybe we can ask Megan. Megan, do you have side effects from the RNS device?
No, The VNS, when I had it implanted, I had paralyzed vocal cords for about 3 months, and they weren't sure if that was going to go away. That was definitely the worst part of it. But from
And
that,
the VNS, you tend to be
Yeah.
able to feel when it's on and off. And I can
yes,
always
when
hear it as an epilepsy doctor, whereas the RNS people don't tend to feel, the DBS people don't tend to feel. Now that's there are definite caveats to that. And if someone is having a side effect to one of those devices, it's pretty easy to change the way we stimulate so that we can make it better.
and I also did the ketogenic diet working with epileptologist at Johns Hopkins. And that for me didn't really work. Definitely helped lose weight very quickly. But I did not notice a reduction in my seizures, but I have heard it work for others. So I think it's just try what you can and hopefully you find something that works or at least reduces them.
We got a question of what to do with epilepsy in your sleep. So that's a great question. So particularly the big seizures at night are a little more dangerous than seizures during the day. And the thing that makes people much, much safer, I wonder if anyone could guess what this is. The thing that makes you much, much more safer if you have tonic-clonic seizures at night in your sleep is to have a bed partner. And that because there's something about the way people breathe after they sleep, they can after a seizure at night where their face can be in the pillow that can really put them at risk. And people just do much better and have far less complications if they have like a bed partner. So if you share a room with a roommate or if you share a room with your spouse or your partner, it actually does make you safer. So some people are really reassured that they have seizures only at night, but those can actually be dangerous and they should be taken very seriously.
The glucose one, there's a couple questions about glucose and seizures. And again, just to cover it briefly, glucose is usually the main fuel for the brain. So anything that originates in the brain, it can spread quickly. If you take down the amount of glucose that you have in your body and the availability of it, it can make the seizures a little bit less. Ketones are just not as much used by the brain to spread these. So that's why we think there's a connection between ketogenic diet, which reduces glucose that you have floating around, and seizures.
But it is complicated because if you have too little glucose or if your glucose is really high, that can also trigger a seizure. Someone asked about a provoked seizure. We use the word provoked in epilepsy if that is truly the cause of the seizure. So if your glucose is very low or very high, or if you just had a stroke and you had a seizure because you just had a stroke, we consider that provoked. For people with epilepsy who have seizures for certain reasons, we consider that the trigger, and we use a slightly different word. We are getting some questions that are very specific to an individual or a few different individuals, and those questions are going to be really hard to answer here, but maybe we can do it offline at some point.
Let's scroll further down.
Yeah, so someone asked that they were taught to live by the steady state, to sleep, diet, drugs, which I assume doesn't mean cocaine, but means like medications, and exercise. Yeah, that's a great approach. Living a balanced life, and the simple basic things are still so important for seizure control and also for like health and happiness.
We also have a wonderful question from Megan about finding
For
support
Megan.
groups. Yes, for Megan, about potentially finding support groups that helped you or finding therapy that helped you manage your anxiety. So I think you addressed a little bit of that when you said you got rid of the friends that were just troublemakers. Yoga sounded like a good idea, but anything else from therapy that helped with anxiety?
I think it's the website epilepsy.com. They have like local groups that you can search for in your area. I've worked with a therapist for several years now for anxiety, and we follow up every few months. I was going to say something. I had something else for that. But it's hard to find people who suffer from epilepsy. I think like well, it's probably more common than you realize, but people don't talk about it. So you're not going to run into somebody in the grocery store or something. But definitely search around, and there's wherever you live, because they're just like, AA meetings. There's probably a meeting somewhere close to you that you're not aware of, or everything's virtual. You can join one online.
Yeah, so we have like 2 support groups, for example, and the Epilepsy Foundation of Metro New York has support groups for folks that are in the city. We just put this back up on the screen because somebody asked to be able to see the QR code for contact, but I'm going to take it down again. So someone's asking if recreational drugs like alcohol are bad for epilepsy. So it really depends on who you are. Over drinking is always bad for epilepsy. Feeling drunk is in general puts you at more risk for a seizure the next day. One drink is, for the vast majority of people, always okay. Drugs like cocaine can definitely worsen seizures, and marijuana, we definitely don't recommend it, but it probably is less likely to trigger a seizure than a night out drinking.
Just one quick question about Megan's response to neuromodulation and the seizures, and if it has any effect on the hypothalamus. And no, again, the stimulation is so gentle and it's far enough away from the area of the brain called the hypothalamus, which would be much deeper and lower inside from that thalamic lead. So the thalamus is above the hypothalamus itself. So Megan is not having any side effects from that part. And then this last one, redefining seizures are controlled by medication. I think it's really important. So when does a person know that their seizures are controlled by medication?
Yeah, so we only, now that we have the RNS device, we do see that the people are sometimes having seizures that they don't know about. And as long as they're small, we don't really count them. The definition of seizure control or drug resistance is if someone's taking their medicine properly and it's a properly chosen medicine, and they're not having any seizures, then it's considered controlled. It's considered drug resistant if they're having seizures after 2 medicines have been tried, either one by one or together.
Yeah, and I think it doesn't really matter the size of the seizure, right? Because again, unfortunately, even if you have small seizures, they can eventually progress and break through into a larger seizure. So any seizure on medication is something to talk to your doctor about and to look for other ways to control it better.
So I think we're out of time. It has been like our absolute pleasure to talk to you. And we know that we didn't answer some of the questions, and we're in some ways only scratching the surface. And living well with epilepsy is something that we could probably talk about every night for a lot of hours. And I think one of the things that would be amazing is to hear from everybody what you're doing to live well with epilepsy, because I think in many ways you guys are the experts. But I want people to be optimistic and to continue to try new things, and to never give up hope that life will be amazing.
So we want to thank you guys all for attending, and we're going to try to do these frequently throughout the year, and we'll work with the team here. But please reach out to us, give us feedback, and feel free to email and contact the center about other things that we can cover and other things that we can do next time to help you guys deal with these.
And we're sorry we didn't get to everybody's questions.
It's a pleasure, everyone.